Hi everybody, this is Module 2, Chapters 3 and 4. We're going to get into epidemiological methods and measurements and talk about study designs with today's lecture. By the end of this lecture, you should be able to describe the natural history of disease, articulate levels of prevention and proposed models of causation, identify select methods of analysis including descriptive and analytic epidemiological methods, and understand variations in study design and their purposes, strengths, and weaknesses. And finally, understand key elements of data analysis, including bias, causality, confounding, and interaction. That said, I want to just give a disclaimer that, this course is really intended to provide you with a perspective on community health nursing practice as an APRN. So, a family nurse practitioner or a nurse practitioner in psych and mental health nursing. I don't think that it's a valuable use of your time to dig really deeply into some of the content that's focused on epidemiological methods and statistics. I think it makes more sense, because you are nurse practitioner students, to focus your energies on making sure that you're clear about the logic behind analysis of epidemiological studies that you may be, looking to for evidence for interventions that you may be, pursuing with your patients, or describing the populations that you work with. And so while there's a lot of kind of depth of content around different types of bias and the whole section on lists of useful formula, calculating rates, and so forth, I think it's valuable for you to read through them to be familiar with different ways that rates can be calculated, but you are not going to be asked on the quiz for a specific calculation. What I'm really looking for with these two chapters is for you to understand the why and the wherefore of analysis of data to further evidence-based practice. That's really the most important part of this piece of the course. So with that said, we'll go forward, but I just want to explain why I'm not going to go into depth and detail going into formulas and so forth. I want you to have some familiarity with why we use constant multipliers for specific types of rates, for example, but I don't expect you to be able to recite any of those. Or, the thing is, as an APRN, you're always going to have access to prepared statistics. You're always going to have access to, websites where you can look for data that are descriptive. You can always look up a formula if you really want to figure something out and look at data yourself, or work with an epidemiologist. But I don't think that it's a valuable use of your time and your skill set to focus your energies on that. Okay. So they describe the natural history of disease, and as APRNs, I think you guys are very familiar, as nurses, with the appearance of disease, and that disease doesn't just appear suddenly, that there's a stage of susceptibility where there's opportunities for interruption of risk factors, and that there's multiple causes, that disease isn't just the result of one cause, that there may be a whole kind of constellation of factors, including history, exposures in the environment, or behaviors that may contribute to how susceptible to onset of disease a person may be. Also, the preclinical stage may predate the appearance of symptoms, but this is again another opportunity for interruption in the development of disease. So, for example, a regular Pap smear can detect premalignant stages of change in the cervix, and so having those opportunities for intervention before disease appears is really critical because it improves the odds of survival and interrupts that onset of disease. And finally, the clinical stage of disease is when you are able to recognize symptoms of disease, and resolution may be spontaneous, but is more likely to be the result of treatment, or resolution may be death. So, for example, cancer staging could be taken in terms of at what point in the natural history of the disease is the cancer, according to the pathology of the cells that are collected. You can determine how advanced into the clinical stage of disease the cancer has become. In that discussion, it does show that non-clinical can also be kind of subdivided into the preclinical stage, the subclinical stage, and then the chronic or persistent stage, or the latent stage. So if you think about tuberculosis, for example, someone who may be exposed to tuberculosis and may seroconvert but doesn't have any active symptoms or evidence of disease may be in the latent stage of disease, as opposed to somebody who's not exhibiting any symptoms and has had an exposure but hasn't necessarily converted. Or they may be in the persistent or chronic disease of tuberculosis, so they may have active tuberculosis. So this kind of non-clinical stage can be further subdivided, is just, I guess, the point that the text is trying to convey. The iceberg phenomenon, and this is a kind of a metaphor that's used for several things in public health. But for example, the iceberg, what you see of the iceberg is usually just a small percentage of what the entirety of what tuberculosis disease, for example, constitutes. That you can have latent TB infection, which includes a larger population, represented by that big chunk of ice that's under the water. People with latent TB don't feel sick, they don't have symptoms, they can't spread TB, but they are in the community circulating, and they could become active at any point and develop TB disease, at which point they would become infectious, and they are at risk for developing tuberculosis. So it's critical that LTBI patients be recognized and treated to lower that risk in the circulating population. The number of people who have active TB is small, and but because they are exhibiting symptoms, they're apparent, and it's an opportunity to recognize and interrupt the chain of transmission, and also improve the outcomes for that individual. So the number of identified cases is always exceeded by the number of unidentified cases. The work of the clinician is typically the portion that's visible, the piece of the iceberg that's above the water. The work of the epidemiologist, and I would say the work of public health in general, is largely below the water. So recognition of the folks with LTBI and getting them treatment is critical to controlling the number of people who progress to active TB. That said, the work of public health is both, that it's the work of health departments and the state health department to contact trace those with TB infection and all their contacts, and provide them all with treatment, whether they have active disease or latent TB. And that constitutes primary, secondary, and tertiary prevention. So what do I mean by primary, secondary, and tertiary? Primary prevention refers to prevention of the progression to disease. So this involves health promotion, disease prevention. It alters someone's susceptibility. So primary prevention reduces exposure and enhances the protective factors of that person. An example of primary prevention for tuberculosis would be recognizing occupational exposures and avoiding them, or taking a precaution by making sure that you get fitted for a N95 mask, and you're fit tested, and you utilize your N95 mask whenever you might be in contact with a patient with TB. And when you go into areas where there may be TB prevalent, you're taking additional precautions, hand washing, and increasing circulation in the room, and those kinds of things. So that's all examples of how to prevent and reduce exposure, as well as increase the protection. Secondary prevention is early detection and prompt treatment. Typically, we think about screening as the predominant way to do this. So in that last example, if we're thinking about tuberculosis, secondary prevention would be if I'm exposed on a regular basis, that I am getting a regular PPD test, and I'm monitoring my exposures, and I'm keeping track of them, and I'm not just sort of, circulating in communities where TB is active blindly. I'm maintaining, a constant level of surveillance in order to make sure that if I do seroconvert and have a positive PPD, for example, I'm able to get LTBI treatment immediately, and then that would be then my tertiary level of prevention. So to prevent LTBI from progressing to active tuberculosis, I would take a course of anti-tuberculosis treatment and slow the progression to active disease, or getting medical treatment if I do have active disease would be another form of tertiary prevention. I'm preventing a worse outcome like death by seeking treatment for my active tuberculosis and preventing it from getting worse or affecting other body systems, my heart or my kidneys or my brain. So the intent of tertiary prevention is to alleviate disability or restore functionality or slow the progression or prevent death, or to promote rehabilitation to a steady state where the disease is no longer progressing. So that's sort of the way that we typically think about the levels of prevention, primary, secondary, and tertiary, is usually in terms of like disease. So, we think about primary prevention as, vaccination, or understanding disease, understanding our risk. Secondary is typically screening, testing, regular mammography, for example. And then tertiary is once you have the disease, preventing it from getting worse, or preventing it from accelerating, or preventing it from causing death. The way that public health interventions think about levels of prevention is the same, but it's often not in such clinical terms. It's not necessarily always on a one-on-one, one-to-one basis. So that last example that I provided with in terms of tuberculosis was focused on like an individual and how they progressed through the natural history of a disease and the opportunities to prevent that disease. If we're thinking about, this is an article, a study that was looking at secondary and tertiary prevention of violence against women in low and middle income countries. And so they looked at, primary it was a meta-analysis, and they looked at what were the opportunities for intervention at the secondary and tertiary level. They said that in terms of primary prevention, that preventing the violence from occurring, so strengthening families, improving communication, preventing alcohol use or excessive alcohol use, were all of those sort of primary prevention strategies. Secondary was to prevent the reoccurrence of violence after it had occurred, so preventing subsequent episode of violence, which is really actually more tertiary prevention, but certainly preventing, recognizing risk factors. So this is where screening programs for violent tendencies or intimate partner violence, history among partners in a relationship, alcohol use screening tools, all came into context. And then tertiary prevention was to prevent death and disability and treat the problems that were a result of violence. So if an injury occurred as a result of the intimate partner violence, preventing that from causing disability, or working on interruption of the cycle of violence and preventing violence from accelerating or interrupting the access to factors that could exacerbate the violence. So drug, alcohol factors, those types of things. And also moving families out of the cycle of violence were all considered tertiary factors. So I just kind of threw this in here because I think it's a good example of like the way that you can think outside of the individual and more in terms of population when you're thinking about levels of prevention. So the text goes into how causation has changed over time and our understanding of causation. The epidemiologic triangle historically was sort of always thought of as like agent, host, and environment interacting. So you need an agent. Let's take malaria, because the epidemiologic triangle was really developed at a time when public health was predominantly focused on, tropical and infectious disease. When we stopped having as much issue with yellow fever and malaria in this country and moved towards, heart attacks and congestive heart failure and diabetes killing people, we had to kind of start changing the model. But the model initially was like, if you think about malaria, agent, host, environment. So environment is a warm, wet environment where mosquitoes can reproduce. So a bunch of discarded tires is a perfect environment for mosquitoes to hatch in small pools of water that get warm during the day and cultivate a great environment for mosquito larvae. The agent in that situation would be the mosquitoes, and then the host are people in which the falciparum parasites that the mosquitoes carry are able to reproduce and cause active malaria. So that's one way that we've always sort of historically thought about epidemiologic triangle. It's changed, I think, because so much now hinges on the environment, both in terms of climate change, in terms of chronic disease. It's very difficult for the agent or the host. Both of those are impacted by the kind of meta factor of the environment. So if we take something like diabetes, the agent would be poor glycemic control. The host would be people with predisposing factors, and then the environment would be those factors in the community that hinder the person's ability to control their blood sugar, and those factors can be impacted both positively and negatively by the ability of the host and the agent to kind of balance out each other. Another model that's been proposed is the web of causation, and it's typically visualized as a web, but I think that it also helps to think about, if you think about the web of causation. So if we're talking about an example like childhood diabetes type 2, you have so many factors that if one outweighs another one, they can cause these imbalances that, if you think about like a web is literally like a spider's web, pressure on one part of the web can throw off the balance of that whole web. And the same can be said of this web of causation. So in this example that I'm providing, the ability of a caregiver, if a caregiver has limited options for after school care or daycare or safe daycare or things like that, because of the family's socioeconomic and then the cost of food, that the options that the caregiver has can be severely limited. Taking all of that into account with a family history of diabetes or a family culture that's sedentary, or the food choices that are available in the proximate neighborhood, or the ability to exercise safely. All of these, depending on the degree to which they play a part, can impact the ability to determine what's causative and what's just sort of associative. So there may be multiple factors at work, and taken in concert, they have a greater effect than they would on an individual basis. So there's sort of these what are these 5, 6, 7, 8, 9 factors that have now become sort of the standard guidelines for causation. Even though Sir Bradford Hill, in the paper where he proposed these causes, kind of causation, a list of causative agents, or causative factors, I think is probably the right way to say it. He was sort of like, this is not a checklist, this is just, things to take into account, but it's not necessarily like, if you have consistency and strength and specificity and plausibility and experiment and analogy, then that tips the scales. He didn't intend it that way. And he also acknowledged that the Surgeon General's report that came out the year before was, iterative and illustrative of a lot of the issues that he was also pointing out. But some of the factors that both of these reports kind of point to are what goes into causation or showing that something is resulting from something else, or something is causing something else to happen. So how strong is the association between things? How consistent is it? How easily can you replicate it? How specific is the cause and the effect? Can you line them up in terms of how they took place over time? So that's your temporality. Is the observed association logically following the precipitating event? Is there a dose-response relationship? So if you increase one factor, does the other factor increase as well, like as a result? Is it plausible that both of these, that this factor is causing this other factor? So is it plausible that when the sun goes down, more night creatures come out, for example? Yes, it's plausible. Is that a dose-response relationship? Is it the less sunlight causes nocturnal animals to come out, or is it a natural cycle? Or are there multiple factors at work? Just as a silly example. And then experiment and analogy. So these are additional factors. Like, are they things that you can replicate? Can you make these things happen again and again and again consistently, that would indicate that it's a causative relationship and not just an association or just a kind of a happenstance kind of a relationship? And then is it analogous to something else? So is the relationship between these two factors similar to the relationship between other two factors that behave in the same kind of way? So you can show that similar behavior between them. So these are sort of the tests that we now think of for causation, and chapter 4 kind of goes into that in a little bit more depth. I was going to point out a couple of other things in that chapter. We'll just get to that part when we get there. Shoot, there was something I wanted to point out. This is what it was. Okay, so that to show a causal relationship requires the elimination of all known alternative explanations. So somebody who's doing any kind of investigation is also going to look at what are some of the other explanations, and can you cross those off the list? And then does it line up with the current state of the knowledge about that topic? Like, given everything that we know about that issue, does our current understanding of that topic also kind of allow us to cross other things off that list of potential causes? So how does data acquire meaning? I should say, how do data is a plural. So you hear people talking about the data, and really, if they're talking about one data point, they should be saying datum, but that's just me and my English major background. So how do data acquire meaning? Statistics can describe disparities, but they can't explain them. So statistics are just numbers, and data are just descriptive until you put some context behind them. They describe risk factors. They can describe their impact on a population, but the reason for that impact is not in the numbers necessarily. It requires additional analyses, but also studying those populations to understand other confounding factors. data also can describe the extent of an existing disease in a population and can help us to evaluate, possible treatments. This is really where we come up with the need for evidence-based practice, that our understanding of the data is what informs our application of those data to our practice. And then, in the chapter, they point out that statistical significance is not always that significant. Just because something shows statistical significance in a study doesn't mean that that necessarily translates into better outcomes on a clinical level. So it's important to always kind of keep that in mind and take that into context. So context is vital. The chapter 3 points out that the MMWR is a report that comes out every Friday. You can sign up for it and get it in your inbox. But it does provide kind of, it provides all of the notifiable diseases and their distribution across the country every week. So every week, all of the cases of gonorrhea, chlamydia, HIV, monkeypox, COVID, every reportable disease is going to be listed out, and the number of new cases and where they were located is listed out. But without some context or understanding, those are just numbers. They don't really provide us with anything. So that's why the MMWR is such a valuable resource, is because it provides us with some of that context. So, for example, the current monkeypox outbreak, if we were just watching the monkeypox numbers go up, we might think, oh my gosh, we're having a monkeypox epidemic. In reality, we're starting to learn that it's disproportionately affecting LGBTQ communities more than heterosexual communities. It doesn't seem to be airborne. It doesn't seem to live long on surfaces. It seems like there's a consistent prodromal stage and then progression to active stage. It's presenting in a predictable way, the way it does in countries where it's endemic. So all of this is in, for example, this week's monkeypox outbreak update in the MMWR. But each week, the MMWR is providing that context that we need to interpret those data. So it's providing the data, but it's also providing the context that you need to make sense of those data. So the chapter goes into how to calculate rates in order to describe how injury and illness are distributed in the population. And so this is how we make sense of numbers of positive cases or numbers of people injured through specific mechanisms. Rates measure those attributes over time, and they identify trends and allow us to compare within and between groups. So our rate is calculated as the number of events that occur during a specific period of time over the average population at risk during that same period of time, times a constant multiplier. And the constant multiplier is specific to the population that it describes. So, for example, if you're calculating an infant mortality rate, for example, the number of infant deaths is so small, but an infant death is such a serious event at the same time that calculation is always per 1,000 live births. So it's always taken in the context of, out of 1,000 live births, what number of deaths occurred among the population that was born alive, or that was born during that same period of time. So the key in thinking about rates is recognizing that anybody who's in the denominator, so below the line here, must have the potential to enter the group in the numerator, and everyone in the numerator must come from the denominator. So the numerator is always a part of the denominator. The denominator has always the ability to enter the group in the numerator. So you couldn't say, for example, it's not the same as a proportion. It's the rate is always an expression of a change over time among a defined population in a constant that's taken in a how do I say this, like a constant representative sample, so that you can compare populations, from a population in Georgia to a population in Maine. You're going to be able to compare those because you're using the same calculation, but you're also comparing apples to apples. So you're comparing the same constant. You're not saying just because let's say the city of Atlanta has a denser population than the city of Portland, Maine, that you're still going to be able to compare the rates because you're taking it per 100,000, for example, as the constant that you're multiplying by. Okay, so that's just, if we're talking about how do we calculate rates. The chapter, as I mentioned, does go into a ton of different calculations. I think those are interesting, but we are not training to become epidemiologists, and you can always go back and refer to that if you were going to, look at a study and really wanted to dig into the why and the wherefore of how they calculated the numbers, or if you wanted to design a study yourself and determine the best mechanism to analyze the data. You could do that, but you have it as a reference in your book. You don't have to understand it intimately right now. What you do have to understand is the difference between incidence and prevalence. So incidence represents new events in a population over time relative to the size of the population at risk, whereas prevalence is the number of all cases of disease in a population at a given point in time relative to the size of the population at risk. So the difference here, incidence is new cases, prevalence is all cases. So incidence describes how often new cases occur, whereas prevalence indicates the burden of disease in the population, like currently. Oftentimes incidence indicates risk because it indicates how quickly new cases are appearing. So when we were talking about when we track COVID, for example, it's more valuable to track incidence, which is the number of new cases, let's say per day, as opposed to prevalence, because we may have 50 new cases in the community, but the total number of people with COVID in the community may be actually like 450. But if you are looking at how quickly the disease is spreading, you're going to look for incidence. If you're looking at how well can our hospitals withstand the burden of people who may need to be hospitalized, you're going to look at prevalence. But it's tricky because with a disease like COVID that has a very short infection period, and then unreliable length of disease, like some people get your clinically acute period may last, 5 days. For some people, the clinically acute period may last for 2 weeks, for 2 months. So it can be tricky, and you really have to look at the natural history of a disease in order to determine which view of the numbers is more valuable. But typically we look at incidence for infectious disease to determine risk and how quickly something is spreading in the population, as opposed to using prevalence to describe chronic diseases and the burden of disease in the population as a whole. So descriptive epidemiology is the way that we describe the distribution of diseases, and these types of reports and studies typically are how do I say this, like, are based on, but also are analyses of readily available data. So these may be census data or hospital discharge data or vital statistics data. And all we are doing is describing. There's no intervention in these kinds of studies and reports and analyses. It's just looking at data that's static, data that's already been collected, and there's no manipulation of the data. But it can give us a lot of information about, the population at risk. It can give us a lot of information about the way that risk works in a community, and so forth. So there's 4 types of descriptive studies: case reports, case series, cross-sectional studies, and correlation studies, which correlation are also called ecological studies. Case reports are written accounts of rare or unusual cases in which the treatment or the management of the disease is worth reporting. So case studies, rounding, grand rounds are good examples of these. It's an opportunity to share findings and to describe responses and highlight treatment modalities. A case series is a little different in that it's a series of these patients that maybe have a similar diagnosis or may come from a similar population or have a similar condition, and it's intended to identify new strategies for treatment for those patients that have something in common. A correlation study is a ecological study, and is used to conduct studies of aggregate or population characteristics. They can only report that a correlation exists. They can't show an association exists as they compare population or aggregate data. They're kind of meta-level analyses. They're really just descriptive, but they do help to set up additional opportunities for more interventional kind of analyses. And then finally, cross-sectional studies are also known as prevalence studies. They're situations in which both the exposure and the outcomes are studied at the same time. They provide a snapshot and give kind of just a point in time. It's not surveillance, it's just a kind of a point in time description of what's going on in a population. They sample the population, they sample the characteristics of that population, and they describe it. It's very difficult to show causation with these kinds of studies, but they're helpful as kind of a foundational way to begin an analysis that may be a little bit more complex. Excuse me. Epidemiologic analysis. These analytic modalities look at causal factors of disease and test hypotheses to identify factors that increase or decrease the risk of disease. They determine association between exposure and disease and determine strength of that association. So these, when we talk about interventional studies, this is sort of more what we mean. It's not just describing static data and looking for trends. It's proposing that this group is different from this other group because of this causal factor. So it's really much more focused on causation. Cohort studies can be either prospective or retrospective. In prospective cases, the investigator begins with a defined population and follows that group who are either exposed or not exposed to a factor of interest over time to compare the incidence of an outcome or a disease. In case control studies, you're taking a group of individuals who have the outcome of interest, those are the cases, and then you're comparing them to another group that doesn't have the outcome of interest, and those would be your controls. So you're watching these groups in parallel as they move through time to watch what exposures they have and what results from those exposures and how that plays out over time. The thing to remember with case control studies is the importance of case selection. You have to be very specific about who's included and are they in the case group or in the control group, because if you mix them up or you don't pay close attention to the criteria for each of those groups, it's very easy to kind of mix the results or the associations that you see between them up, and then the validity of your study can be called into question. It's important to also, with case control studies, make sure that all other explanations for an identified association have been eliminated. So you have to really kind of make sure that all the similarities can be explained and all the differences can also be explained, and that the things that you're the variables in question are things that you can isolate really well. And then finally, randomized control trials are considered the gold standard for evaluating treatments and assessing new ways to deliver health services. We'll talk in a couple more slides about the challenges with randomized controlled trials, specifically in community, because of the difficulty of controlling for other factors that may be confounding. But they are considered the strongest way to provide evidence for evaluating a treatment or backing up an intervention. So well-designed studies, what are the components of a well-designed study? Some variables not being studied may affect the results. So it's important to always kind of be on the lookout for factors that may mess up your study. Well-designed studies identify the impact of variables and avoid bias or design flaws caused by other variables not being studied or taken into consideration. When a researcher draws a wrong conclusion because of a problem with a study design, the result is a type 1 or a type 2 error. And I want to just pause here because null hypothesis, I think, is not very well explained in the excuse me, in the book. I think if you're not, I think I really am having a hard time with some of the things in the textbook, because I think that this is obviously a textbook that's written for somebody who's going for a PhD or a doctoral degree in nursing, and somebody who's planning to do research, because they spend a lot of time talking about sensitivity and specificity and very complex functions. And I don't know that that's necessarily, serving you guys very well. I think the point of this course is really to be able to read a study and read it critically and be able to determine, was this a well-designed study, and do the conclusions make sense? Are there any other like holes that you could poke in the logic of a study in the way that it was designed and carried out? I think that's really where having these kinds of analytical skills can be useful. But that said, I feel like the chapter there's in both of these chapters, there's points where they throw around terminology, but they don't explain it very well. So that was just to kind of get to the point of explaining what null hypothesis means. A null hypothesis means that there's no difference between the intervention or no intervention, or between two treatments. So if you have a type 1 error, it means a null hypothesis has been rejected when it's actually true. So you are saying that there's no difference between treatment 1 and treatment 2. And actually there is a difference between those two treatments. So that would be a type 1 error. A type 2 error is where a researcher fails to reject a null hypothesis that is in fact false. So in that case, the researcher failed to reject the difference that did occur between treatments, and so they were ignoring the difference. So they were like not seeing that there was actually a difference, and in fact there was no difference. So it gets very complicated, and it doesn't necessarily need to be. It's not really that important, but just to understand that there are type 1 and type 2 errors that really, the whole null hypothesis thing is not as important as understanding that these kind of errors result from errors or flaws in the design of the study, where the researcher is not seeing what's actually going on, or is assuming that something is going on that is not. I think that's probably the easiest way to explain it. So what are some of the types of errors? So the easiest type of error, and the one that's kind of the most forgivable, is random error. Random errors tend to be, they're random. So, it's like if you throw a dice 50 times, 25 on average of those, I'm going to say that wrong, not a dice. If you flip a coin 50 times, 25 of those times it's going to come out heads. It's about 50% odds that it will be. So errors will be either prevalent in equal amounts because of random factors. So these are things that are more forgivable because they're sort of like a naturally occurring error. Systematic errors are really more serious because they impact the validity of the study, and the ability to extrapolate meaning from that study. They're typically broken down into selection and information bias. So selection bias means the selected subjects in a sample are not representative of the population of interest, or the comparison group. And so it makes it seem that there's an association between an exposure and an outcome that is not actually there. It's just the people who were chosen for the study. So they don't represent a group accurately. Information bias, there's several types of information bias. The chapter kind of goes into a ton of them. I just want to point out a few of them. Measurement bias is a form of information bias. It occurs during data collection, so it can be something as simple as the tool that you're using has a scale on it that's 1 to 5, and everybody chooses 3 because they don't want to hurt the person who's conducting the study's feelings, and they're like, everything is fine, everything is okay, it's not super good, it's not super bad, it's just fine. That's a problem with the tool. Whenever you're designing a tool, go with an even number so that people have to choose, like it's either on the good side or it's on the bad side. That will give you more meaningful data. Another type is misclassification bias, where a control may be recorded as a case, or a case is classified as having an exposure that they didn't actually have. So this is a confusion in the carrying out of a study. So somebody who was supposed to be in one group was actually, taken into another group, or they kind of were misclassified, and that misclassification can mess up your results. A contamination bias is similar. It's like when somebody kind of migrates into a different group, or is accidentally exposed to a different factor that is supposed to be linked to the other group, and so they're kind of being contaminated by that other intervention. So for example, you have a group of people, and you're asking them if they saw billboards, on the side of the road, and unwittingly there were similar billboards that were also up that were not associated with your study. So the people were interpreting all the billboards that were up as, being the ones associated with your study, and they were responding to that, but it was being contaminated by, this other factor that was not necessarily part of the study. And then publication bias and citation bias are they go into them in the chapter, and I just want to point out that these are situations where, so there's generally a bias towards randomized controlled trials, for example. There's generally a bias towards quantitative data analyses versus qualitative data analyses in scientific journals or in medical journals. That there's a tendency to publish a higher percentage of studies with significant results than those with non-significant or negative statistical results. So it makes it seem like things are significant that are not necessarily significant. It's just that more people have, had access to those data sets and reported on them because the results are more obvious. Whereas, you may find more revealing clinically significant data in smaller analyses, or in analyses where it wasn't a positive outcome. It was actually the unintended consequence of a treatment that showed value. So some of those can it's just a recognition that there is publication bias, and that there are factors that you should take into consideration when you're looking at the source of your evidence when you're considering an intervention. Confounding occurs when it appears there's a true association between an exposure and an outcome, but in fact this association is confounded by another variable. I liked the example that they gave in the chapter, and so I'm just going to read part of this. It's that they were looking at a study in rural communities and urban communities in Japan, and found that those living in a rural community, there was an association with stroke that was independent of other risk factors. but after further analysis, they determined that the link may actually not necessarily be between rural and urban environments so much as between differences in the weather that each of those areas experience, because low temperatures are known to cause an increase in coagulation factors and plasma lipids, and therefore differences in weather could have an impact on the incidence of stroke. So it's not necessarily that people who live in rural environments are having higher stroke because they live in rural environments. It's that people who live in rural environments are more exposed to the elements that the weather is causing them these higher rates of coagulation and predisposition to stroke because of the colder weather. So it's important to just be thinking about those variables that may be part of the population, such as their gender, their environmental exposures, those socioeconomic factors that are outside the variable that you're studying, but maybe impacting the outcome. And then interaction is 2 or more factors that are being studied, and one factor impacts another one, either augmenting it, like synergistically increasing it, or decreasing it, so working against it antagonistically. So those are also factors. If you want to kind of pull apart those confounding, it does, the study, the text does point out that to reduce the effects of confounding, you can look at how participants are randomly assigned to treatment and non-treatment groups. And then in terms of statistical analysis, a multivariable regression can measure the effects of multiple confounding variables. But this is, again, you have to be able to kind of parse out what's a variable that's recognized and acknowledged to be associated with a certain outcome and which ones are not. So it's difficult to kind of break those pieces apart. So finally, I just wanted to go back to randomized controlled trials, acknowledging that yes, they are the gold standard, and if you could, isolate the really key piece of an intervention that made all the difference, you would, but they're not always practical in community settings. People, they interact with their environment, they interact with each other, they come from various backgrounds in terms of their educational background, their cultural background, their language familiarity, so many different factors. So, well-designed cohort and case control studies are good alternatives when randomized controlled trials are not always feasible. But the thing to keep in mind is that so much of it is really about analyzing the methodology and determining where are there kind of flaws in the design, and just taking those into account and determining, are those enough to invalidate the results, or are they just sort of pieces of the story and things to take in context. Databases are a great way to look at data that's a little bit cleaner, but then they are also, usually involve participants that were able to stick with a long-term study, or were able to access care, and so they're part of the hospital study. You always have to kind of think about what's going on in the background in terms of the data that you're looking at in those participants. But these are key to designing a study or intervention that can contribute to evidence-based practice and or be used as evidence for your own practice.